7. I'm calling it. I wanted to welcome everybody to today's panel addressing the nursing care shortage. My name is Elena Rivera. I am the health reporter with KERA and NPR in North Texas, and I have been at this role since 2021. This panel is going to be recorded, as you might see in your Zoom. Everybody is going to remain muted, but we recommend that y'all submit questions either through the Q&A feature or the chat feature. And we're probably going to group those together and ask the panelists these questions if there's time at the end of the hour. And I want to start by thanking today's host, Bob Kalin, who's the Vice President of Long-Term Care Options for Molina Healthcare of Texas. And I am going to turn it over to him to get us started.
Thank you, Elena. Welcome to all of our guests and everybody who's joined us this morning. And on behalf of Molina Healthcare of Texas, we're looking forward to this important conversation. Our panelists today represent different sectors of healthcare industry and bring a wider range of expertise and backgrounds. We're all grappling with the same issue of nursing care and the nursing care shortage. Whether you're in a hospital, a doctor's office, assisted living, a nursing home, or even home care, it touches every patient in the healthcare system in some way. Ensuring that we not only have consistent pipeline of nurses, but also for them to stay in a job that requires a lot of long hours and a huge emotional toll on them. It's crucial that we have the nurses there to strengthen our industry in the long term. Molina Healthcare of Texas, in collaboration with Molina Cares Accord, is glad to serve as a partner to organizations that are prioritizing the nursing shortage and working to recruit and retain nurses, particularly in underserved and rural areas. The Accord was established by Molina Healthcare as a commitment to building stronger communities, one life at a time. We must be proactive in getting ahead of the issues today and ensure that our healthcare system is well equipped to support the current and our future demands. To kick our conversations on this pressing issue, I'd like to introduce today's keynote speakers, Maureen Milligan, President and CEO of Teaching Hospitals of Texas, and Jackie Brock, the Chief Nurse Executive and Executive Vice President of Harris Health System. Maureen served in various roles at the Texas Health and Human Services Commission for 16 years, and work is focused on state and federal health reform, state healthcare policy for Medicaid and indigent care, and Medicaid operational and contract management. Jackie's background includes more than 30 years of nursing leadership, experience in critical roles advancing healthcare organizations, including Parkland Health and Hospital System and Medical City Healthcare in Dallas. Thank you to Maureen and Jackie for being with us today.
Hey, good morning, Bob. Thanks everyone for inviting us. Thanks for having this important conversation. So we really appreciate everybody's interest in this topic, and we're looking forward to this conversation. And everybody knows, like you said, Bob, that nurses are the lifeblood of the healthcare system, and they've been stretched and stressed really to their limits under the pandemic. So Teaching Hospitals of Texas has been working with our chief nurse executives like Jackie, you'll hear from her in just a minute, for a couple of years now on this particular topic and what they faced under the pandemic. And as a result of that work and that study, looking at the literature and what's out there, talking to people in the industry, including our nurses, our fundamental message is pretty simple, is that Texas's historic investment in nursing workforce is critical. But it's insufficient to meet the needs of Texas's nursing workforce going forward. So why do we say that? The primary obstacle that's identified by School of Nursing faculty, why can't they admit more nursing students? What they tell us is, and what they've told us for the last several years, is that it's a clinical capacity issue. Well, what does that mean? I mean, you guys are in healthcare, you know what that means, but when you're talking to people maybe who aren't as familiar with this, what that means is that the education takes place, about 1/3 of nurse students' educational time is actually in a clinical setting. That makes sense, right? They have to learn to work with patients, learn the systems. What do I mean by that? Do I mean hospitals because we're teaching hospitals? Yes, but is that all I mean? No. So, you know, Rachel and Bob, we mean long-term care settings, clinic settings, and the variety of settings that the Board of Nursing will allow preceptors to engage in and be defined as preceptors. So as you guys know, preceptors are the nurses who are spending time in the clinical setting, who do what they're required to do and have to do every day to take good quality care of their patients. In addition to that, they have a nursing student or two that's with them constantly throughout the day to teach them. And again, that's about a third of the time that nursing students spent is clinical capacity. So that's the number one obstacle identified by School of Nursing faculty in reports over at Department of State Health Services. So what does that mean? It means that we should look to investments in clinical sites. One other thing about clinical sites that they can offer is they are the place where you look at issues like retention, like nurse workforce safety for nurses and everybody else in the clinical site. Also things like retirements, people shifting away from the work environment. And then the other thing is this thing called experience complexity gap, which many of you may know about. But what that means is that when you have most experienced nurses retiring and leaving the workforce, who does that leave you with? You have a larger percentage of your total nurse workforce that's relatively inexperienced and new. So how do we leverage those few remaining, thank goodness for them, nurses who are staying around? How do we leverage them to better teach and support the new, less experienced nurse folks that are in the clinical settings? So here's the problem, is that currently Texas's investment in nurse workforce is only through, or predominantly through, schools of nursing. So we say that that's a critical investment, schools of nursing, because that's where a lot of that education takes place. But if we're going to shift and meet the needs of the future and actually address these issues of growing our student bodies, growing our nurse workforce, retaining them, what we need to do is shift our investment strategy and also focus on clinical investments. Like I said, hospitals, nursing facilities, clinics. Why? We've seen that be really successful in graduate medical education, right? The Texas, maybe less than 10 years ago, Texas legislature said, we're going to set a goal, 1.1 GME slots for every medical student so we can retain our investments in them and we can have those professionals in Texas. And so what we haven't done yet, though, is make that same kind of investment on the clinical side. Again, if you look at where the funds are going today, schools of nursing, we think that's great. We just think it needs to be expanded. And I want to ask Jackie to talk a little bit about what we're thinking about here, but we need to expand that investment so we can get the whole picture of nurse education and also address the challenges in the actual clinical sites. So kinds of funding we can use, ARPA funding. So that's funding that had supported the nurses that came in during the pandemic. That's queuing up at the governor's office, about $2 billion there. And then secondly, GR dedicated funding for a longer term kind of continual flow of investment into nurse workforce and the other workforce challenges. So Bob, I'm going to be quiet now and turn it over to Jackie.
Thank you, Maureen. Thank you all. I'm happy to be here. Like we said, I'm the CNE at Harris Health System in Houston, Texas, and like everybody across the country, facing a nursing shortage. We had a nursing shortage going into the pandemic, and it's even worse now, hitting a little harder. So a few of the things that we talked about with Teaching Hospitals of Texas that I've been advocating for, and the CNE CNO group has come up with, and we've all been advocating for, is around preceptor pay. This is something that many of us already do when we are asking our staff nurses to precept a new employee, but we just don't have the funds to be able to extend that additional pay when they're precepting and teaching the nursing students. And I think it's important to note that, yes, this is part of, I believe, a nurse's job, that we're to teach and to bring the profession along behind us. But when I started, I might have a nursing student one day a week. Now we have nursing students every day of the week, on shifts, off shifts, weekends. So we're asking our bedside nurses to do more. And as we've increased our nursing graduate population, as we need to do and need to do further, even increase further, that 1/3 of that education has to be taught at the bedside. So we're asking those bedside nurses to do more. So I don't want to take a penny away from the academic support that they've been getting from legislature, but we want additional funds to support that education at the bedside with those nurses. And one of the ways that I look at it is, as I have to push more, and not just me, but every CNE, CNO that has to push for our nurses to do more, I would like to have some funds to be able to pay them to support that ask, to support that push as we're asking them to do more. And then in a recent conversation I had with one of the deans of a nursing school, and I totally agree with his idea, is that we also need to change the perception of that work at the bedside, that the nursing students are not a burden, but they're actually a benefit. So working in hand with the nursing schools and being able to pay our preceptors would be ideal. We're also asking for funds to support innovative programs around resilience. Some of us have been able to afford programs around resilience to bring in third parties to help support that. Some facilities just can't support that, but resilience and retention is key. And so we're asking for funding from the legislators to help us support resiliency programs and to support our retention. And then also some creative education beyond the academic preparation and pre-licensure education that gets a nurse licensed. We have to have continuing education, ongoing education, specialty education and further development once they're in the hospitals. And we would like to have some funds to support some grants to be able to do creative things and trial things, looking at not only simulation, which is pretty widespread now, but some virtual reality, artificial intelligence, and incorporating some things and pilots like that into our education. So we're asking for funds, again, not a bit to take away from the academic support, but to support the part of nursing education that goes beyond the academia. So, thank you.
Thank you so much, Maureen and Jackie, for sharing, and for Bob for introducing them. And, you know, just for Molina Healthcare of Texas, along with Molina Cares Accord, for bringing us together today. I'm going to give a brief intro to our panelists, and then we'll kick it off. Joining us today to have this wide-ranging, and already my brain is turning with all the things we've been discussing, is Rachel Hammond, who's the Executive Director of the Texas Association of Home Care and Hospice, Antonio Johnson, Vice President of People Engagement from Cantex Continuing Care Network, Nate Moore, Chief Operating Officer of T-Care, and Dan Pollock, who is the CEO of Adventist Medical. And I think we're going to kick it off by talking about the pandemic, which we kind of referenced a little bit already, and obviously has impacted so much of our work. The healthcare industry is still feeling immense effects from COVID-19, especially as we're talking today about a dwindling workforce, a changing workforce. According to the Texas Workforce Commission, 23,000 registered nursing positions are still unfulfilled, which means a lot of patients don't have the access to care. And so, Dan, can you set the stage for us a little bit and talk about the healthcare landscape before COVID and the changes you've seen over the past 3 years?
Sure. Thank you. Good afternoon, everyone. You know, before the pandemic, we saw travel nurses accept contract assignments to go see new cities, to build their resume, and for a sense of adventure. Through the pandemic, demand increased for staffing in every single healthcare facility, and travel nursing demand really skyrocketed. And we saw nurses leave staff positions to take travel assignments for the first time ever. And really the major motivator was money. And this was a new dynamic. I think it was very new for nurses to have to get out on the road, to live in a city that they weren't accustomed to get used to a new facility, especially a facility that was probably under a great deal of stress and pressure. Through that, you know, burnout increased, nurse-to-patient ratios got stretched, and we saw clinicians completely leave bedside, which you know, further made this problem even more acute. So, you know, what's happening now? Well, you know, as census has somewhat normalized and dropped, we've seen the demand for travel nursing also drop, and pay packages have declined. We're seeing nurses go back and accept staff jobs, or maybe, you know, reapproach their original facility. And I think that doesn't mean, though, that the staffing demands at these facilities have been met. And so we're seeing the facilities be really creative about trying new techniques to fill the shortages, creating internal resource pools. In acute care facilities, we're seeing facilities hire more LPNs to help out along the RNs. We're seeing more CNAs be hired. We're seeing virtual sitters and sitters to take the jobs of the CNAs to free them up. So there's a wide variety of techniques that I think we're seeing healthcare facilities do to continue to combat the staffing shortage.
Rachel, I'll toss it to you. How was the home care industry impacted by the COVID-19 pandemic? I think especially in terms of staffing issues, which we're talking about What are some of the bigger issues facing the industry right now?
Absolutely. So home care, I think like all of the industries felt the impact of the nursing shortage. But what's unique for home care is that it's such a specialty niche. And also the impact for home care was that the home care industry really didn't get a lot of the emergency funding. Primarily a lot of the emergency funding went to hospitals because hospitals were majorly stressed. We saw it, a lot of emergency funding going toward nursing facilities. And then within the context of the state's own emergency system and the creating kind of this pool of nurses that hospitals and nursing homes could pull from, we were left out of that conversation. So we were already short in the nursing world in terms of being able to, meet the demand. And then what we saw is during the height of the pandemic, agencies were not able to offer some of the benefits and the higher pay packages that we were seeing offered, one, through the travel nursing. We lost a lot of nurses as well to the travel industry, and they were going back into facilities to work, and then also just going into facilities to meet the demand of the facilities at a much, much higher rate. And so we lost nurses in that regard. And so we were unable to keep or retain those nurses. And now that the pandemic is over, wages per se, were quite inflated. And although we're seeing wages come down some, they've not come down enough really for the home care industry to still recruit, retain, or attract those nurses. Nurses are still attracted to facility level pay scales. And so we're left with a much more limited pool, and that's put us in a significant shortage for our nurses.
I'll also remind everyone who's listening, if things that the panelists are saying are bringing up questions, feel free to use the Q&A or the chat function, and we'll get to those if we have time at the bottom of the hour. Nate, switching gears a little bit, a recent Washington Post article highlighted that, despite this nursing shortage we've been discussing, a lot of nursing schools are turning away more qualified applicants than ever before because there just aren't enough instructors. How can the industry bridge this gap to make sure that talented young people remain interested in nursing before they might move on to other fields?
Yeah, thanks for the question. And I'd start by saying this is a complex issue, right? And this is not, there's no silver bullet to this that's going to be easy to fix. And I think as regulators, as employers, as partners, as influencers in the industry, we all have a role to play here. And I want to broaden the question just a little bit, because I think we have to confront not just the questions about the capacity of the schools, but we also have to lean into the churn that we're seeing, and forgive the term, but the churn that we're seeing within the industry. And part of that is about compensation, right? Part of that is about the stress and the burnout that our nurses, or more in general, some of the folks that provide services to the patients in the facilities. This is hard, right? This is stressful. And this is something that I think all too often, especially before the pandemic, but clearly now, I think the public at large has recognized, hey, this is not an easy thing to do. And one of the things I think is really, really critical is that we're going to have to institutionalize efforts to reduce the stress and reduce the burnout of our nurses. And the needs for one individual are going to be very different from someone else. And that's where I think you often have to tailor the efforts around each individual at their city, in their rural area, in their location, to what their needs are. One of the things my organization focuses a lot on is providing services to folks like nurses who are caregiving to individuals. And we see that as part of the whole solution, but it by no means is going to be the only thing. But that's a great question. Thanks so much.
I think the big takeaway, even though it has been 19 minutes, is it's really complicated and there's a lot going on. Antonio, I'm going to switch to you. Cantex Continuing Care Network has nursing facilities across Texas, but a lot of senior nursing homes are closing, which is a combination of a lot of the things we've already discussed, but also financial issues, low Medicaid reimbursement rates. How has the nursing shortage affected seniors? I think especially like Nate was saying, seniors in rural areas. How do you kind of think through solutions to this problem that has so many different parts?
Hey, great question, Elena. The combination of financial issues and the low Medicaid reimbursement rates are adversely affecting all companies who operate within our industries. The nursing shortage specifically has affected care provided to all seniors in all areas. Seniors throughout the industry have experienced longer response times, expressed greater complaints, and been challenged with receiving the type of care they deserve. As we await the decision on greater Medicaid funding and resources, some of our solutions have included greater transparency with seniors and their families, prioritizing quality care and customer service with the staff that we have, utilization of the interdisciplinary team to help the nursing staff in a greater capacity, and of course, prioritizing recruitment and retention of nursing staff.
Yeah, no big deal. Just a bunch of very interrelated, complex issues. Switching over to you, Dan. I think that it's good as we're reflecting to also talk about last year in 2022, which saw massive upswings in hospitalizations for things like RSV and flu. How do companies like Advantage determine where to send nursing staff, especially when responding to things that might be unexpected or seasonal changes in health needs? I'm wondering, is there like a normal baseline anymore? Or is that kind of out the window?
Yeah, out the window. But, I think in 22 with RSV, I mean, we saw spikes in pediatric nurses and the demand for them. ED nurses were in great demand all over the country. And right now, currently, med-surg seems to be the hot specialty of the day. We use, at Advantage, we use BI and technology to kind of monitor demand. We can watch it daily, weekly, and monthly and see the spikes. It's easy to, watch the demand. The much harder part is making successful placements and matches with facilities. And we choose to partner with facilities who we could, form strong business relationships with, who actually treat the clinician like part of the staff and not just a contractor on the side. That is an issue in travel nursing where, the travelers feel like almost like second-class citizens and not part of the team. And so we choose to focus where the facility treats them like part of the family and where we can have long, successful placements that increases the care levels and the satisfaction for all parties involved. And then also, part of the matching process does require, the pay to match the nurse's needs. And so that's a tug of war that's happening right now. The facilities are trying to bring down bill rates and nurses are kind of digging in their heels in some situations to kind of maintain that elevated pay.
We've talked a lot about health centers closing, the challenges with pay, I think some of the access issues. Nate, how can telehealth options open up healthcare access to patients, especially folks in rural areas? How can healthcare technology be helpful for patients and caregivers?
Yeah, that's a great question. I think telehealth and technology in general is another tool in the tool belt, right? It's one of those things that we're going to have to pull out and leverage because frankly, it's all about meeting people where they're at with their expectations. I think one thing in healthcare, and I've been here over 25 years, often we like to think we're different, which we are. But I think sometimes we have to take a look at what other industries, especially highly regulated industries, have gone through and the journey they've been through. And I think their recognition of meeting people where they are and not throwing clinical terminology up in front of folks as kind of a barrier to getting things done. I know we sometimes talk about patients and members, and everybody else would say customers. And I think sometimes we may have some things to learn there. because telehealth and technology can really help us connect. Sometimes that's connecting, like we are today over video. Sometimes that's connecting asynchronously, right? So I personally, I prefer to get a text as opposed to a phone call. And so I think we've got to recognize the needs of individuals and meeting them where they're at. And that, frankly, in the rural communities in the state, in the urban communities of the state, some of those things we're going to find really do provide some of the benefits that we're all looking to folks to get to where I would say, as much as anything, treating people as people. I think the pandemic taught us a lot of things about all that. And again, telehealth can help us there. Technology can help us. But I do think we've got some things that we should continue learning about.
I've been speaking with a lot of sources who I've been talking to about setting up health appointments, and some folks have said, no, I want the paper. Send me the paper. I want the paper in the mail. I have terrible internet. I don't look at my phone. I don't want to have to access a patient portal. And then I've had other folks, a lot of friends who say, it's so nice to be able to look at the app and apply, or like have a video call when I don't have time to go into the office. I think there is a lot of flexibility with telehealth and a lot of things that have opened up as we've been thinking about it. And I think similarly, Rachel, thousands of disabled and elderly Texans rely on home care for their daily lives, for doing everything that they need to get done in the day. What is the impact on folks who need this care, who can't find a nurse or a provider?
Well, that's a really good question, because sometimes home care is looked at as kind of this separate service off, on its own, that doesn't necessarily have an integrated impact on the continuum of care. And in reality, it really does. Because what we see, and what we're seeing now, for instance, particularly in the private duty nursing space, and those are nurses who work in the home setting with medically complex children. So children who might be living in their homes with technology on ventilators, who have complex medical conditions that need a nurse, right, to stay healthy. And so right now we are at a significant shortage of those specialty trained nurses to take care of children. And so when that doesn't happen, and when families, for instance, don't have access to all of the necessary hours to keep their children healthy at home, what happens is then the family unit itself gets significantly stressed, because, as you can imagine, if you are a parent of a child who is on a ventilator and requires interventions all throughout the day, 24/7, and you have to have eyes on 24/7, and you don't have the nurse there, then who's left to do that? Then it's the parent who's left to do that. And what we're seeing in households is that parents, to the detriment of their own health, are attempting to fill in for those nurses who are not there. And so then what happens is the child gets sick, and the child ends up back in the hospital. And as we saw, particularly during the increase in the flu and the RSV and that kind of pandemic of its own, or that hospitals were stressed, because then what happened is children went back into the hospital, then they were ready to be discharged. They were clinically appropriate to be discharged back home, but the family didn't have the nursing support there. So hospitals were hesitant to discharge those children home because there wasn't the nursing support in the home. So then at that point, children are staying in a hospital longer. We have reports of children staying in hospitals for 40 days or more, millions and millions of dollars later before they could even get home. That's not good for the family. That's not good for the child. And so home care has a impact really on the overall healthcare continuum, whether it's hospitals or nursing homes per se. We're talking about seniors, right, in the home. If they're not getting the care that they need at home, then something happens. They either fall or experience an adverse event, end up in the hospital unnecessarily. or they are just not getting the supports that they need, so they can't maintain their life in the community anymore and are going into nursing facilities. So that's what we're seeing in the home care space right now.
Yeah, a lot of these different layers that impact all these different parts of the system, right? And I think one thing that we've talked about a little bit already, but definitely is worth mentioning again, is this issue of burnout. I think especially for our frontline healthcare workers dealing with an unprecedented global health event that was changing sometimes every day, every week, every month. Antonio, how can healthcare organizations better support workers to make sure that they stick around for the long term?
So Elena, I think we can all agree that burnout remains a trend that's shaping the employee experience for both frontline healthcare workers as well as leaders. To better support workers and ensure long-term retention, I think healthcare organizations must really recognize and act on the factors that are causing burnout and understand what workers value. Employee burnout is typically due to a combination of bad processes and inefficient systems. Also, the doing more with less cycle, work-life imbalance, and to Nate's point earlier, sometimes it deals with the people element from an ineffective relationship with manager and/or peer situation. So organizations that essentially effectively and consistently demonstrate a willingness to act on the burnout factors while promoting an environment in which employees can grow and develop will essentially be positioned for success.
Dan, I'm going to toss it to you and your experience. What has made the difference in keeping employees happy, feeling supported? Maybe what are some ideas for the industry at large to motivate and encourage current and future staff?
Sure. When we're placing travelers, we're hyper-focused on really two phases. One is getting the clinician successfully onboarded. I think far too often we kind of throw nurses onto a floor and the onboarding process can be very disjointed. When you're traveling to a new city, that's stressful enough. Starting a new job at a new facility, that's also stressful. So we want to make it a smooth experience, making sure that their housing is taken care of, making sure that they have first day instructions, they know what to expect. And then that first day and first week, really get off on the right foot. From there, it's about constant communication throughout the assignment, which is incredibly important. You know, are they working the hours and shifts that they desire? Are they in an environment where they can thrive and they can provide great care? Nurses want to be great at their jobs, and are they able to do so? Do they have a good working relationship with their unit manager and their coworkers? All very important things. You know, we've talked a lot about burnout, and I think and mental health, and people maybe jump to, okay, well, we need to offer therapy, and maybe that is the case for certain clinicians. But there's also a large continuum between no support and therapy. And so what do you do in that area? And I think for us, we have clinical directors who work at our staffing agency. These are former unit managers, former ICU directors, and they act as like a career coach and an advocate for the nurse. They're available for coaching and issue resolution and crisis resolution. And they're there to be somebody just to maybe the nurse needs to vent to, or they want to brush up on some of their clinical skills prior to starting an assignment. I think those little bits of support can make the experience so much better, keeps the clinician happy, which improves the quality of care. And I think the community, the healthcare facility, and the clinician all benefit.
Like we were saying before, seeing people as people, patients, and folks working in nursing. Antonio, are there any specific actions from an education perspective that might incentivize nurses to work at long-term care facilities, or any other solutions that we maybe haven't talked about that you think we should mention?
So another great question, Elena. I think, you know, to everyone's point earlier, we must continue messaging the benefits of a rewarding career in long-term care. The demand is so much great, and that's going to continue to be the case overall as the U.S. population ages. When considering advancement opportunities, I think a lot of nursing students need to know that they can go on and become either nurse practitioners or get involved with executive level leadership. And even to Maureen's point from earlier, there needs to be greater collaboration amongst schools, clinical programs, organizations, and elected officials to support initiatives that rebuild the long-term care workforce and ensure long-term long-term availability of talent pipelines.
For sure. Rachel, I think we've talked a lot about funding and that being a really pertinent issue when we talk about nursing shortages. What do Texas home care providers need from the state legislature? They're meeting this year, this session, to keep the industry staffed for this continuing demand.
Very good question. Home care is unique in some ways that they're very limited on their payer sources. So the primary sources of income for home care agencies are Medicare and Medicaid. There's not a lot of diversity in payer sources for home care. They have very limited private insurance because they work with seniors who are on Medicare, and they primarily work with individuals with disabilities or children with complex medical conditions whose coverage is primarily through Medicaid. So really, those are the two primary funding sources. So as you can imagine, it makes it exceptionally challenging for home care agencies because we're heavily reliant on government payer sources. So obviously this legislative session, particularly in Medicaid, because we do provide a lot of long-term services and supports to individuals in the community as alternatives to nursing home placement, or, you know, kind of until they're ready for that. Or obviously we do provide services to children as well with medically complex conditions, and we're reliant on funding from the state budget. Unfortunately, our appropriators have really not necessarily prioritized funding for long-term services and supports for a number of years, well over a decade, quite frankly, 16 years. And so by kicking that can down the road, the problem doesn't get any better. It just gets worse and much more expensive. So this year, we're really at that crisis point. As I mentioned earlier, from a nursing perspective, particularly in the private duty nursing space, we are unable to meet the demand anymore. And we're seeing a significant rise in hospitalizations for children with complex conditions. So the price tag for that obviously is high. If we're going to get nursing salaries back up to kind of a competitive wage with other parts of the healthcare industry, where nurses feel like, well, I can go somewhere else to make a better living. Likewise, in the long-term services and support side, in supporting seniors and individuals with disabilities, again, those wages have been ignored for an extended period of time. So Texas, unfortunately, is the lowest payer in that regard for individuals who provide long-term services and supports for seniors. So the price tag, unfortunately, is really high. And in order to do that, Texas is just going to have to invest and make that investment now. It's a big price tag. However, also look at that as a cost containment measure, because we understand and know that services within the context of the community are a more cost-effective way to serve individuals. Not to say that it's appropriate for everyone, and not to say that other parts of the healthcare continuum might not be needed down the road. However, it is a cost containment method. So if you invest in, for instance, private duty nursing, we're lowering unnecessary hospitalizations. So that's bringing down the cost of care. Likewise, if we're investing in long-term services and support, we're allowing more individuals to stay in the community longer. And so we're decreasing the cost of care as well. So they really need to make that investment now. And then for the long term, look at some policy decisions and how we support the home care part of the healthcare continuum long term, so that we're not in this crisis position that we're in at this moment.
Nate, what actions do we need to see from state and federal leaders or the industry when we're talking and thinking about innovation, as we have, with telehealth, with approaching mental health, all these different things?
Yeah, that's a great question. And I think, reflecting on the comments of my fellow panelists, what I would say is it's really clear that if we don't change, if we stay within the status quo, things will be not sustainable. And so if we acknowledge that, one of the things I'm hoping we can think about, and we're really looking for folks who will be partners, who will be willing to give some flexibility for the various players within the industry, and who really are looking for some experimentation. Obviously within good close guardrails and things like that, because we're all focused on those consumers, those patients, those members. But I think flexibility and experimentation and finding things that work in a different way, that are cost effective, and frankly, that really drive to what those consumers are looking for is part of the new equation that we're going to have to build together. So sometimes in the past, there have been folks who would often say no first. I think we're looking for partners who will say, let's work this together and find some things that do work. And when something doesn't, we can move on beyond it. But that is really how innovation happens. We're going to have to try a few things because if this was easy, it would already be done. And frankly, it's not done.
Before we head to our Q&A, I just want to check in with any of our panelists, see if there's anything that we want to say before we head into our wrap up, or anything that anyone said so far that has kind of sparked something new or you're thinking about. Or not. I've learned a lot. I'm here. Well, thanks to everybody. Thank you so much. Before we start the Q&A, I'm going to bring Bob back in, who is lovely on camera now, into the discussion. Bob, can you talk a little bit about Molina Healthcare of Texas's view on the future of healthcare staffing in the state and the role of collaboration and partnership in this work?
Sure, but first I want to thank all of our panelists, to Rachel, Nate, Antonio, and Dan for joining us today. And on behalf of Molina Healthcare of Texas, I want to thank everybody who's taken part in this conversation. As far as what Molina is doing at this point, we have a partnership with Mission Care. And through that partnership, we're looking at various programs to help support workforce development. So a few of the programs that we're working with them on is My CNA Jobs, which is a job platform that providers will be able to post jobs on. There'll be a way for us to actually have an invitation sent out to individuals saying, hey, join this conversation or to learn more about becoming a caregiver. So it's a recruitment tool that we're going to offer to providers to be able to use to recruit at like a CNA level. We also have, as part of that program with Mission Care, is Coach Up Care. Coach Up Care is an innovative platform to help providers retain staff, to develop programs to help them reduce turnover. So again, it's a program that we're offering for providers to become part of, to really try and give them another tool in their toolbox to help retrain their staff and to help them recruit staff. There's also part of the program is a home health aid scholarship program. So we're looking at sponsoring 500 people to take a 75-hour online home health training. So Rachel, maybe that'll help you out a little bit with bringing in some more home health aides for those folks out in the community. So that scholarship program is part of what we're sponsoring. And then we're another program within that Mission Cares is a 6-hour family caregiver certification program. And it's really about reducing the need for professional caregivers by strengthening family caregivers through better training, which what that really does is help alleviate some of the pressure on licensed type staff or other professional staff. And, as Rachel alluded to earlier, it's that whole cycle of people who are in their homes receiving care on the LTSS. Family members are a big caregiver of that. And when that system starts to break down, the person bounces into the hospital through the emergency room, and it puts a lot of pressure on those types of institutions. So, that family caregiver certification program can little pressure relief valves to help in that respect. Another thing that we've done, and actually we've done for the past several years, is through the Texas Healthcare Association, which is the nursing home association. We've actually sponsored nursing scholarships. So how that works is nurses who are currently working in nursing homes may apply for a scholarship to go from LVN to RN, or you may have a nurse aide or a medication aide in a nursing home who can apply for a scholarship to actually become an LVN or go into an RN program. So we've sponsored those scholarships through THCA for the past several years already. So, we've got a multi-pronged approach through Mission Cares, as well as our work with THCA to address the best that we can and hope to support providers in that search for staff and retention of staff. But I think Antonio alluded to, some of the retention things that have to happen. And, I spent 30 plus years operating nursing facilities, and retention has always been a problem at a nursing facility level because it is, the pay scales aren't quite as competitive as hospitals and things like that. So had to become very creative about retention programs. And I think that's something everybody has to look at is what are they really doing for retention? And what I learned through that is that we listened to what the staff told us would help retain them, because sometimes what we thought would be a great retention tool really meant nothing to a staff member. So, listening to your staff, I think, is key in developing those kind of retention programs. So that's really about all that I have. Again, I'd like to thank our keynote speakers, our panelists, and you, Elena, as our moderator, for starting the conversation, and all of us having this, this conversation, getting different perspectives from different types of healthcare providers. I think these kind of conversations help generate collaborative ideas and action. And hopefully what we can see is some action through our state lawmakers, as well as our industry leaders all working together to address the shortage of healthcare providers out there. So Melina, we're happy that we're able to convene this panel today. And, it's everybody out there, like our panelists and all of those of you who are providers out there. It's what you do every day that makes a difference in Texas. So thank you.
Thanks so much, Bob. Now I'm going to turn it back to y'all listening on your Zooms. Shockingly, you also get to be a part of this conversation, I promise. We're going to do a couple minutes of a Q&A. I'm going to ask that you submit your questions using the chat feature. You can also use, if anything has struck you from this conversation, if it's getting more information from one of the panelists about the work that they do, or a bigger question you have about the landscape and the work that we've talked about. As we're waiting for things to cycle in, I think one question that I have been thinking about as we have been talking is sometimes it can feel pretty overwhelming to have conversations like these and list every single issue that might happen in the industry, and figuring out kind of where to start when there's so many places to fix can be a little overwhelming. I'm wondering for y'all, for anybody, what feels like a kind of easy first next step, or maybe easy is incorrect, but what is the first step in trying to address this nursing shortage? Where is kind of that kernel that someone might start with or think about starting?
Wow, Lana, that's a difficult question. Where would you start? I'll talk to the providers on the phone and on the call today. I think for folks that are thinking about traveling or getting into taking a contract type of assignment, it's really important to find an agency that's going to support you. I think clinicians today, there's a percentage of the population that honestly, they want a completely digital experience. So they're using some of these staffing platforms and apps. Bob alluded to one earlier, the My CNA Jobs, and they prefer that through the cycle. But there's a lot of staffing companies who, they're more of a brick and mortar staffing company, and the recruiter will really act as your agent. They'll educate you on the process, on pay packages, on the facilities that are going to place you in. And it's a way, I think, for the nurse to maybe get a preview into a potential assignment, as opposed to maybe the more traditional way where if they're just applying to one facility, they don't have a broader view of the market. So there's a lot of different agencies, a lot of different avenues out there. I think it's about finding the agency that's going to support the clinician the best.
Mm-hmm. Well, and I think we talked a lot today about issues that require, or solutions that require collaboration. Bottom line is that there's just not one approach to trying to address the nursing shortage. And so, case in point, we have a lot on the agenda for our legislative session, particularly to address the challenges that we have with workforce. But we're not the only one that's experiencing workforce, right? All of us are experiencing workforce. And so what we've seen is success in, for instance, working with hospitals who are experiencing the stress, right, of not being able to discharge medically complex children home, in working with us and messaging that out and saying, listen, this is addressing their issue. However, their issue has an impact on us. And so as we're trying to solve for these problems, collaboration is something I think that is key, particularly because we're all also very interested in the pipeline and kind of where it all starts, and getting the nurses interested in and then through nursing school and the training. We're certainly looking at ways at which home care can be a viable clinical site, because quite frankly, we do a lot of very highly skilled things in the home. It's just the challenges are different. We're not all in one place. It's, all our patients aren't grouped together. You're having to travel over, miles and miles to get to places. And so we're working with the BON, for instance, on what does that mean and what would that look like to be a clinical site in the home care world. So collaboration, I think, is something that we all need to think about really heavily, and how we could work together to address pipeline issues, education issues, and then issues and look at these things as affecting all of us in the continuum.
Yeah, just to kind of echo what some of my fellow panelists have said, I did also think it's going to be important for us to acknowledge that we have a crisis, right? Mm-hmm. And talk about that, and acknowledge doing nothing the problem will not go away. I actually think that first step is actually really, really critical. And then we have to be willing to go shoulder to shoulder with sometimes our competitors and our partners and try some new things out. So, but acknowledging that first thing, yeah, we have a crisis, and do nothing, it just won't lift. That's part of what we have to do too.
Yeah, I mean, I agree, Nate. Like the status quo is not working, and there's breaks occurring in the industry. When you look and hear, over 50% of healthcare facilities are running negative margins. They are losing money. That cannot sustain itself. These facilities will go out of business, and that's the worst thing. And we're seeing even negative events from some of the negative margins. You're seeing hospitals close floors and units in their facilities. So now the community is suffering. If they don't have a certain surgery center is now no longer open, or certain floors no longer open, and they have to, patients have to travel even further to get this care. Unless we address the money piece and get these healthcare facilities on a stronger financial footprint, there's going to be this tension in the space in the market, and it's a huge problem. We have to fix the money piece.
I think that's a great segue into another audience question, which is, how is the quality of care impacted by compensation, and is keeping up pay rates getting more difficult with inflation? Someone from the audience asks.
Well, certainly from our perspective, our rates have not kept up with inflation at all. And so its impact to quality is that we don't have the staffing to provide the services. So you have individuals who have been assessed as needing a certain level of care to maintain their health at home. And when that care is not delivered, then something usually happens, an adverse event happens. And so therefore, those services are going to have to be obtained somewhere else. So it impacts our ability to provide quality services. And part of that quality is ensuring that all of their needs that they've been assessed are met. And so that's just right off the bat, we're not able to meet that. Likewise, it impacts our rate of turnover as well. So when you have an industry that has a high turnover rate, and in this industry, particularly in the LTSS space, we're over 100% turnover rate. There's no way that you can maintain a quality workforce with over 100% turnover. So turnover is has a huge impact on the quality of individuals and the quality of your workforce as well. So to Dan's point, you have to fix the money piece, and then you look at, what is that long-term fix, and keeping the money piece stable, and then you can actually participate in a lot of these very innovative things such as value-based and quality-based initiatives. If you don't even have the floor to support value-based arrangements and quality-based arrangements, then there's no way that you can get to that space.
And Elena, I'd like to add to that, I concur with Rachel and Dan, but one of the other issues that we're dealing with, not necessarily from a compensation standpoint, is clinicians who are essentially just looking at what they do as a job versus the actual caring element for patients and residents. And, we have staff members, solid nurses across the board, solid CNAs across the board, who ultimately want to work with other individuals who have the same type of passion that they have. But I'm pretty sure everybody on the panel will agree, sometimes you just don't know what type of clinician you're going to get in terms of really wanting to care for the patients and residents who we work with.
Mm-hmm.
Yeah, I would add in about the pay. So this problem is even larger for, unfortunately, our small and rural healthcare systems and facilities. The issue is, the large facilities have purchasing power. They're part of big GPOs. They can buy equipment and supplies at lower rates than maybe a small facility could. And what we're seeing is, the smaller the city, the more rural the town, there's at times when they have to pay a premium to the cost of living that you would see in a large city. And that makes it's this, this cycle that's incredibly difficult for these facilities to turn a profit. So absolutely, pay does impact quality of care for the individual who asked the question. And it's interesting because it's every facility. There's some facilities that are incredibly well run, and let's be honest, there's some facilities that aren't run as well. So the administrators also, bear a burden in becoming better at running their systems, being more innovative, trying new things, so that they can, pay the clinicians more than a fair wage.
Well, we have 2 more minutes left, so I'm just going to read a comment, and then we have a couple of other questions. I think we're going to direct those to specific panelists when we wrap up. But this doctor who's listening in says, as a physician, I'm mindful of the impact of my physician orders placed on nursing staff. Do I really need a medication that requires multi-dose scheduling versus once a day? Can we safely keep a patient under good observation with a virtual nanny versus a nurse? Every little effort helps my nursing team. And so I think that speaks to Antonio, what you were talking about in terms of it's about the people, it's about the work. How do we see each other as people collaborating in this larger space on this work that we do every day, that, the reason you do the work is because it's for the people, to care for them. And I thought that was a really insightful comment. But because we got 1 more minute left, I'm just going to wrap up really briefly. I'm so grateful for everyone's time. I'm so grateful for all the incredible questions. If we didn't get to yours, the panel will follow up shortly afterwards. And as a reminder, this will be recorded. So if you missed anything, you can go back and revisit. And I will turn it back to Bob for our closing remarks.
Thank you, Elena. Thank you, Elena, for moderating for us. And thanks again to all of our panelists for being part of the conversation, and to each of you who joined us here today about the various perspectives. Hopefully, you can take something out of this, take it back to your organization, and at least start a conversation or have some conversations. But we all play a part in strengthening Texas for the future. And this is about the future. We have today where we are, but we also have to look where are we going with all this. So, it's about collaboration, and all of us may be competitors in different markets and different parts of healthcare, but at the end of the day, we're all there really to care for, our Texans, and we want the best for them, and we have to work together to get that done. To learn a little bit more about Melina's work in the state, you can go to melinacares.com, and that's also going to have some more information about what Melina has been doing in terms of workforce development. So thank you to everyone again for joining us today, our panelists, to our guests, to Elena, and everyone have a great afternoon.